Good morning, everybody. Let me start with a few comments. I don't know how many of you have thought about the fact that historical paths determine a lot about medicine. You know, we use blood pressure as a key variable, heart rate as a key variable. Have you asked why? Likely because that was measurable in the 1800s. Now, can we measure other things today? Absolutely, but we're not using them because the practice of medicine has evolved to follow a set of rules. And I think a new set of rules are possible. It's an artifact of historical precedent, not the best medicine we can practice today. Where are we today in medicine as I see it? And by the way, this is no fault of those of you who are doctors. They do the best they can. Medicine has gotten a lot better. Death rates have declined. So no fault. It's not criticizing medicine, only saying we can do better. And that new approaches allow for much more rapid improvement. So where are we today? Let me give you an analogy. Google has a driverless car. If we were to allow Google to get that car on the roads the same way we allow medicine, we'd say, Google, you can have a car on the road as long as any one car has only one accident a week. That is roughly the error rate in medicine. And that's what we can change and improve, even though it's improved a lot. You know, the fact is today, if you have cardiac disease, most likely you'll discover it by having a heart attack, which is sort of sad. There's more ICU deaths from diagnostic errors and other errors than from breast cancer, though we treat breast cancer as a major disease and ICU deaths as sort of a hidden thing behind the curtains. My favorite is the new DSM-5 psychiatric manual, the Diagnostic and Services Manual, where basically psychiatrists are saying kappas or correlation coefficients roughly are 0.2, which means 3 doctors don't have to agree on your diagnosis, they can treat you anyway, is acceptable medicine. That is the most recent state of the art in psychiatry. So I think what we have to do is change the practice of medicine into the science of medicine. And for the first time, I believe tools are in our grasp to do this, and do this very rapidly and effectively. And you've heard from many speakers here on what they're doing. One word of caution, transitions matter. How this technology and new approach and new workflow gets inserted into daily practice will make it more or less acceptable, move faster or slower, so you don't walk into a hospital and fire all the doctors day one. I think amplification of what doctors do today, while our toddler little tech systems grow up, while they learn from the best, is absolutely important. And assistive technologies, bionic assist, as I call them, is very important. Having said that, let me postulate that though biology is not unimportant, data science will do more for medicine, data science broadly defined, than all the biological sciences combined the next 10, 20 years. Interestingly, while it's doing this, we'll have what I call my 5x5 matrix. 5 times less errors, 5 times lower cost, 5 times less work per doctor. They can do other things. 5 times faster But here's the interesting thing, 5 times the number of opportunities to do real biological research. Data will surface correlations that we can then examine on a research basis, so those of you who are biologists or researchers, don't be disheartened. We will increase the number of real opportunities to investigate things. There's a popular story around the IBM Watson system and the p53 enzyme, I think, that all of you, if you want to understand, should read. This data collection we do will change diagnosis, prescription, and monitoring in really, really interesting ways. I think for the first time, we can get away from opinions. It scares the shit out of me if 3 doctors give me different prescriptions, and they do all the time. The very fact that treatment protocols, care guidelines, whatever you want to call them, inside each hospital system are different, mathematically proves they all can't be right for any given patient. There's no arguing that they can't all be. So there is one hospital system that probably has the right best path for the average patient. Almost all others are suboptimal in some way, and they're based on the opinions of their committees, expert doctors who happen to have their own biases. Now, it will get much better because you can get personalized guidelines for one patient, and that's what we should all strive for. Already, we are seeing early advances in machine vision, in machine learning systems, change some of the simpler disciplines, radiology, pathology, ENT, dermatology, even reading ECGs. It took 6 months for LiveCode to get their algorithms where they're better than the average human cardiologist in reading the ECG and detecting atrial fibrillation, lower error rate. So that's sort of the promising opportunity. What I get most excited is about new medicine. There was a great paper based on machine learning done at Stanford. It was called the CPATH algorithm to read cancer biopsies. And what this system discovered, that after decades of cancer pathology practice, pathologists and textbooks had not discovered the right way or the most efficient way to diagnose a tumor. Not only did the systems get as good as humans, they discovered new features which are obvious in retrospect. For example, the edges of the tumor and the behavior of the edges is more important than the center of the tumor. That's new medicine, and I think we'll see tens, if not hundreds, of these for every disease state. Some combination of heart rate variability and skin temperature or blood glucose surfacing some specific condition. When I ask my doctor, why is my sugar higher on some days more than others, I get the same answer. No idea, but drink less coffee, which I don't drink much, eat well and exercise. It seems to be the standard prescription for almost everything. It just feels wrong to me. And I think you've heard about new tools coming. Continuous monitoring of vital signs. We have a company that's doing 400,000 vital sign readings a day per person, out of about 40 or 50 million raw data points a day. It's sort of fabulous to watch this device. Though data itself is not that important, turning it into insights that says, oops, you should be doing this or changing your diet because your blood pressure is going up. And oh, by the way, doctor's prescription's wrong. Coffee doesn't do anything, but extra alcohol actually makes a difference for you. Those kinds of insights based on continuous vital sign readings. We have another company, Applied Proteomics, that reads 300,000 biomarkers out of each blood sample. And I think Larry Smart talked about microbiome. These are all new tools that will be an integral part of medicine and will surface new medicine. That's what all of you should be excited about. I do think with these new tools, over time, our toddler little MD systems, which the press will make fun of early because they'll make stupid mistakes, it's the nature of technology. You don't get perfect day one. Neither does a human toddler. But these in assistive mode will get better and better till they're very easily much better than the best humans. I can't imagine there'll be too many things, there may be a few, that I would rely on a doctor for 20 years from now, on opinions, or diagnosis, or monitoring, or prescribing treatments. Now, you may need doctors for other functions, so I'm not saying you eliminate the doctors, but you select doctors for other tasks they might have to do. I suspect compassion will be an important piece of it, what people call the human element of care. But if that's true, and I suspect it will be, then you should select the most humane humans, not the highest IQ people who could get into Stanford Med School. We might actually go to UCLA Film School to find the best doctors. Select for mirror neurons, not IQ. I don't know. I just think it's unpredictable today. So with that, let me try and finish and open it up to questions because I mostly want to have a dialogue. Let me make two final comments. I think as we get to better and better care, the kind I'm talking about, the patient will become the CEO of his own health. I think Peter Diamandis, who's here someplace, said this originally. I'll attribute that to him. And I think that's a really exciting thing because all the studies show that when doctors pick prescriptions, treatments for patients, they tend to pick more aggressive treatments than patients would for themselves if they were fully informed. And I think we will get there. Let me finish by saying the following. Not everything we do will be successful, and many of you will struggle trying to do things, but it's still worth doing. I urge you to try and fail, but not fail to try. That also is not an original quote. I forget the source. Why don't we open it up to questions?
So there's mics on each side. When you guys come up, I'll start with the first one. You've seen a lot of industries grow and have helped build them. What lessons can you take from the success and failure of some of those that could apply to the big endeavor of trying to shift biomedicine?
So a lot has happened in many industries. Let me answer the question this way. Did YouTube change media, or did NBC? Did Walmart change retailing, or Amazon? Did NASA change space launches, or SpaceX? Did General Motors change electric cars, or Tesla? My point is the following. Change almost never, large change and large innovation almost never happens from inside the system. Even if people know what to do, there's too many vested interests. It's a lot more convenient. There's a lot more aversion to the kind of risk-taking needed for innovation that almost certainly it'll happen on the fringes, and it's some small markets growing exponentially, not a head-on change of the system. So that's good news for anybody trying to be entrepreneurial. How many people here are trying to be entrepreneurial, start their own company? I love those hands.
Question over here.
Yes.
Hi, Vinod. It's a real pleasure to be here with you, and thank you for joining us. We've heard yesterday about personalized medicine, and you touched on that. We are also hearing about how population management doesn't work, but it does. So I'm curious, for you, where do you think the line gets drawn? Because it's a continuum. In some cases, population management's effective, and in other cases, personalized medicine is. But there's that gray zone. So how do you see that continuum?
You see, population management is fundamentally based on statistics. And then beyond that, it's based on what people call evidence-based medicine. Two problems. Statistics correlations aren't causation. And the median person or the average person gets the right treatment under population statistics, but most people don't. The other side's of the bell curve. So clearly, precision medicine, personalized medicine, way, way better than population management. The second problem I have with evidence-based medicine, which everybody's trying to go to, most of our evidence may be wrong. Dr. Ioannidis is probably the premier expert I know in the country on medical studies. Published a PLOS article where he says any given medical study is more likely to be wrong than right. Think about this. He took the best publications, Science, Nature, stuff like that, New England Journal of Medicine, and analyzed and said the sample sizes are too small, there's all kinds of biases. In fact, in one talk I saw, he identified 249 different individual biases that affected these. So if any given study is more likely to be wrong than right, then what we should be doing is not practice-based, evidence-based medicine. We should be doing, based on historical practice, practice-based evidence first. Let's use all those medical records to rerun every study that's been run, every bias that's been introduced by a device maker, a drug maker. Let's redo those studies. It takes seconds to do. If you have the right database, let's verify what works, and let's identify what doesn't work and for whom. Because it's not possible that the same aspirin works the same way for all 7 billion people on this planet. That's population statistics. Sorry, long answer.
Thank you.
It actually turns out that 1 in 3 Caucasians at least have a gene where they don't benefit from aspirin. We prescribe it to many folks, but they still have the GI risks and risk of bleeding, but not the...
In fact, 30% of people do not metabolize aspirin. Another fact for many Indians here, Indians need about twice the dosage of statins to be effective, and statins have generally not been safety tested in the range it's effective in Indians. If you're Japanese, your statin metabolism rate is probably twice what the average white Caucasian rate is. So this is what's wrong with population statistics. But why stop at Indians or Japanese? Why not my genome?
Exactly. Peter.
And I think you heard a lot about that yesterday.
Exactly.
Good morning, Vinod. Thank you for joining us. If I had a medical school, I'd give you an MD.
I'll consider myself one. Enough people think I have one. I'm good at pretending.
So I think a lot of the revolution is going to come from companies we haven't heard of in this yet that are going to, it's not going to come from inside the large pharmas, inside the large companies. And one of the interesting reasons why I think is that they have armies of lawyers to keep them from tripping over any FDA rules and regulations. And so the question I have for you is for your mindset and how you advise the companies that you're investing in, because for me, a lot of the advantage that startups are going to have is they're going to dance around the regulations, they're going to come up with new business models that avoid the regulations, and they're ultimately, if they need to, go and launch outside the US if they don't like the FDA regulations. And a lot of companies, a lot of large corporations here are not going to do that. How do you think about sort of using the regulations as a disadvantage for the large corporations versus, say, a differentiator for the startups?
Absolutely true. Like I said, finishing up, let's try and fail, not fail to try, right? I think that was Seneca, something old philosopher. I think it's really important to do two things. First, big companies do not innovate. I hope I make that clear. Otherwise, NASA would have, or Lockheed would have done space launches the way Elon Musk did. Risk-taking is the key to innovation. And failure is a part of risk-taking. I find most people in large organizations, and even in small organizations, like to reduce risk to the point where their probability of success is high, but the consequences of success are inconsequential. I like to say, and I urge all entrepreneurs trying to be exponential, that a 90% chance of failure is okay if you have a 10% chance of changing the world. And that's sort of fundamentally, I don't mind failing if the consequences of success are actually consequential.
So you have a pretty interesting investment.
By the way, regulation, I urge all of you to recognize that FDA regulations apply to less than 5% of the world's population. They do not apply to most of the people on this planet. Yet we seem to be driven by it. And entrepreneurs who are driven by reimbursement codes and payment systems and optimizing, they do a useful thing. I'm less interested in it. I'm interested in the technologies that invent new medicine at the point of care or new care delivery systems that make it better, less error-prone, faster, less costly, and worldwide applicability.
Yeah, hi. I think innovation should bring the cost of medicine down, but some of the best innovations we've seen recently have actually brought the cost of medical care up. So for example, in the news would be a treatment for hepatitis C. Cures hepatitis C, cost for treatment is about $90,000 to $100,000. Now the insurance companies are freaking out. They can deal with $100,000 if the condition is rare. But hepatitis C, for example, is not particularly rare. It's very common. So the thinking would be, let's figure out how to limit access to this innovation to the smallest number of people possible. So the question is, how do you bring innovation into the population, in particular the US, when the cost seems to be so high and it's not coming down?
So you bring up an important point, and I want to emphasize, I'm sort of an optimistic type, but I recognize reality is pretty tough. Drug approval for a drug company is a non-trivial task. It's expensive, it's failure-prone, it's unpredictable. The regulations are set up to protect consumers, and they actually have a good reason to have those regulations. The FDA overall does a pretty good job. All of us would like it to move faster, change, but the consequences of taking too much risk at the FDA level are not great. So I don't fault the FDA. I actually think where the consequences of something are not being wrong is not hugely negative, the FDA has been pretty progressive. It didn't take us very long to get over-the-counter approval for the AliveCore device or for the algorithms to read ECGs. So I think we can't blame the FDA because their job is protection and at the population level. The answer is more innovation, faster. More explicitly saying the FDA should look at the negative consequences more than the positive consequences will increase the level of competition. So hepatitis C, the drug, it's a question of if there were 3 competitors and generics, it'd be much easier. And people ask me this question, like, is every area open to innovation? I suspect not, but everything I've run into is open to innovation. So hepatitis C drug, I believe most drug companies are using very old methods, and data science should reduce drug discovery failures by 90% or more if applied properly. I think Larry Smart talked about, I asked the yesterday, they have some amazing results in drug discovery. So could you, I was tempted to start a software-only drug discovery company. And so that will increase competition. Innovation's possible in almost every domain I look at.
Right. Last question, short answer.
Sure. Really trying to understand what the surgeon or healthcare provider will do in 20 years. My expectation is, we're coming with these capabilities to them today, and they should be enthusiastic, and we're going to help them do their jobs better. But we see a lot of resistance. So Is there a story that we can tell a healthcare provider that this is what your world is going to look like in 20 years?
Well, change is always threatening. Two comments I would make. There's a lot more money in wellness or profitability in wellness than in well care than in sick care. Two, whether that's right or not, maybe this thing is destructive, and technology was destructive to the newspaper industry, for example. I can't predict, but no matter which one is true, if in fact this change is going to happen, the healthcare providers who lead the revolution will get larger market share. And those who lag and resist will be the first ones to fail or get hurt by the revolution. Revolutions are never fun. Revolution by itself means somebody gets hurt, things change, there's disruption. Disruption can be a positive word or pretty negative word. Thank you all very much.
Thanks, Vinod.
Thank you, Daniel.